guys, hi, hello. I know I'm here still alone again. I didn't give a heads up for today's video, but I thought maybe to follow up on the online video I did yesterday, and so I was like just getting off work right now, and I felt like, hey, let me just quickly come in and make a live and just throw in like maybe a 30 minutes 20 minutes video, and then I can go catch some sleep, and I'll be back tonight to work. So let me give it like maybe like 30 seconds, 1 minute, for maybe anyone who wants to join in. And yeah, guys, I was just wondering, for nurses out there, would you guys still prefer being night shift or day shift? Speaking of my own experience working day and night, I feel like I am loving my night shift because it's much more calmer. There is no administrators breathing down on your neck. Refine your documentation, do this, no phones, people breathing down on your neck. You have to be on your A game, keep things tidy, family calling, all that. Like when I did day shift for almost 2 years, because I didn't know anything else to compare it to, I felt like it was okay. But now that I've been doing night shift for almost 2 years as well, I think that I prefer, or I love night shift as opposed to day shift, because night shift is more chill, it's more calmer. There's no family members that you have to be going back and forth explaining things, or maybe they're asking for water, or their patient, or their family member is something is weird, or can they call the doctor to come and explain something. Or during day shift, there's like patients going for procedures, patients have to sign consents for whatever thing that is going on with the patient. But my worst thing during day shift was discharges, especially that paperwork for discharge. It was just a nightmare for me. So yeah, that is one thing about day shift that I don't miss at all: the discharge procedure, like calling reports, preparing the paperwork, transferring or making sure the patients have their home medications intact, updated, maybe sent to the pharmacy. Those were things I never liked about day shift. Following up with doctors. And sometimes there were some tasks that I felt like doctors are going to throw at you, the nurses, like, hey, put in this order for these. I know to an extent we nurses can do that, but during day shift I felt like there was just too many orders that some doctors, not every doctor, some doctors were just throwing at we, the nurses, and I'm just like, no. I remember I've had like 2 episodes or 2 times that I had problems with doctors just because I was actually very busy with another patient, and I explained to the doctor that, hey, can you go ahead and just put in the order? And the doctor was like, hey, I'm busy. I'm like, okay, I'm also busy, so doctor got mad at me, but he ended up putting in the orders himself because, hey, I was busy with another patient. Matter of fact, the patient I was busy with, I was in I had to call a code sepsis on the patient, so that was me being busy. So there was no way I could get out of that code sepsis just to come put an order for a patient whom you think it's much more urgent. If you felt like it was urgent, just go ahead and put in the order. Anyways, I was just trying to compare day shift and night shift. Again, I would love to always remain in night shift, but I know sometimes life can happen and I might find myself going back to day shift. But for now, I feel like I'm loving my night shift. It is much more relaxed, calm. Most of the times when the patients are sleeping, there's nothing else to do, honestly. But again, there are certain things that will happen only during the night, like, hey, maybe patient's heart rate can drop, maybe the breathing too can drop, because, hey, when you're sleeping, you're much more calmer, your respiration can drop, your heart rate can drop. Like I said, some patients will wake up suddenly with maybe like a migraine, a headache. Some patients who might have like crazy blood pressures during the night, believe it or not. And yeah, but again, I still love my night shift over my day shift. Okay, that being said, I feel like I've been talking for too long. So given that this video is going to be a video that I want to like enlighten people more on what a step down unit shift looks like. So I just wanted to, kind of continue on the same topic of the live show that I had yesterday. Anyways, so I want to give another example of should I say my night shift last night, the shift I just came out of like 30 minutes ago. So like I said in the previous video, step down unit, I don't want to say most of the times, but the current hospital where I work, we always will have, no matter what, we always will have 4 patients for 1 nurse. And that is one thing I've really much appreciated about this hospital, is that they always stick to the 4 patients for 1 nurse, especially on the step down unit. ICU, they will stick to 2 patients for 1 nurse. When I, as a step down nurse, is being floated to med-surg, the most number of patients I can have is 5, whereas med-surg on med-surg units would have 6. And they're very strict about it, like no matter what, they will never give me 6 patients, like no matter what. Anyways, with that being said, so last night I had 4 patients. Let's say patient A, B, C, and D. So typical patient A had came in with like kind of like stroke-like symptoms, so we had to be doing our frequent neuro checks and documenting that, and as well as doing the NIH once every shift and documenting that as well. So 9 p.m. came around after, getting shift reports, reading notes, updating yourself with like what procedures, if at all, what the doctor's notes, maybe physical therapy, speech, case management, respiratory, pulmonary, the lung doctors, maybe oncologies, or whatever specialty doctors are following for that patient. So after I'd read all my notes for the patient, then it was time for me, pretty much to start giving my medications. So in the hospital, patients can be scheduled medications, let's say for night shift at 9 p.m. so as at 8 p.m. you can start giving medications. So I go into patient A's room, and the reason why I even went into patient A's room was because the telemonitor was beeping and the patient's O2 sat was 60s, 50s, 40s. Then I ran into the patient's room. It took a while for the patient to even bump up from that 38 to like 50s. Then for safety purposes, when a patient is in an acute state, you don't leave the patient. So I just had to poke my head out and then call the nurse who was in the nursing station. Hey, please call the respiratory therapist to come ASAP to the patient's room. So while the patient O2 was climbing up, then it became stable. Now the patient now started having like shortness of breath. Patient started having pursed lip breathing as well as abdominal breathing. O2 sats were now fine, but the patient now was also tachypnic. So called the respiratory therapists. They came, they gave the patient breathing treatment. It did not help, so I had to call the doctor, and the doctor was like, hey, so I had to call the doctor, and I was like, hey, this is what is happening to the patient. Same thing that happened last night. Last night we did an x-ray, and then we gave the patient morphine for air hunger. Do you think that we should still repeat the same thing, that put in the same orders for the patient? So the doctor put in the order for a one-time morphine for air hunger, which did not even help the patient. The patient was still very tachypnic, still breathing and blowing the air through the mouth and all of that. So reached out to the doctor and said, hey, we've done everything and the patient is still not getting any better. So the patient was like, the doctor was like, hey, tell the RT to hook the patient to a CPAP. So we tried to put the patient on a CPAP, but unfortunately the patient became agitated and was screaming and saying, hey, take out the CPAP. They wanted the CPAP out of their face right now. I can understand some patients with CPAP and BiPAP, especially if it's not something that they use at home, they become anxious. Some patients become claustrophobic, and so it's uncomfortable. And so I can understand why this patient was like, hey, take off this mask, I don't want it. And they became very much agitated, so we had to take it off. The patient was even becoming more tachypnic, like in the low 60s, sustaining in the high 40s, then low 50s. So reached out to the doctor, told the doctor, hey, this is what is happening. The patient is refusing the CPAP. The morphine still hasn't done anything. Breathing treatment, respiratory therapist is still here. What do you want us to do? So the doctor was like, hey, just call a react on the patient, and then maybe the patient will have to be moved to the ICU. So call the react, the team comes on, and they were like, hey, let's try the CPAP and see if the patient is going to do any better. So when the react team comes to the patient's room, the patient then accepted or agreed to be put to their CPAP. So CPAP comes on onto the patient, and the patient is still very tachypnic, but we're trying to tell the patient, hey, calm down, calm down. Patient is still very tachypnic, but hey, there was nothing we could do. We just kept the patient on the CPAP, and I had to stay there to see if the patient will even stabilize. I was pretty much in that patient's room for maybe 45 minutes. The patient had medications that had already pulled, scanned, and popped out. So I asked the patient, hey, do you think that you will be able to take your medications? And the patient was like, he's going to try. So they said, okay, let's see if taking the CPAP away from the patient is going to calm the patient down. For some reason, the patient became much more calmer when they took off the CPAP, and the patient took their medication. The respiratory rate came down to the 20s. It was normal. Took their oral medications. Patient had their heparin, which I administered, and then it was, had to wait for a couple of minutes, like 10-15 minutes. Then the patient started becoming tachypnic again, so I had to put the patient back on the CPAP. All along, the respiratory therapist was at the bedside. Had to put the patient back on the CPAP, and then we gave it a couple of minutes. The patient was still tachypnic, but at least it was like in the high 20s, mid 30s. So it was an improvement, so to speak. Gave an order for an ABG, which looked normal. I sent the results to the doctor. So patient becomes stable. I now walk out. Meanwhile, while I was in that react situation, one of my other patients was having the same issue as this patient that I was in the room with, but it was less milder. The patient was just having abdominal breathing, and the patient wasn't necessarily tachypnic, but the patient's O2 demands had to increase. I had to slap the patient on more oxygen on an oxygen mask from a nasal cannula. We suspected that the patient had aspirated. They did a chest x-ray, which kind of did not agree that the patient aspirated, but the chest x-ray showed that the patient had something in the lungs. So the doctor comes on, looks at the result, interprets it, gave orders for like Mucinex for the patient to cough out, gave a one-time order for Lasix. Believe it or not, it helped the patient. The patient was much more calmer. Anyways, the patient became calmer because after all that x-ray and increasing the patient's O2 needs in terms of bumping the patient's oxygen up, and switching the oxygen from the nasal cannula to the oxy mask, the patient still had their night medications that I had to give them. So I had to crush it, give it to the patient in applesauce, and one of the pills in the medication was trazodone. So I believe the trazodone really helped to calm the patient, because all night the patient slept. And during the time when the patient was having that abdominal breathing, the patient became also agitated, so agitated than the previous one, that we had to put the patient on restraints. So that was my crazy night. And then my third patient, I had a crazy night last night. My third patient was more so an issue of blood pressure, like blood pressure 180s, and then at about 4 a.m. the patient's blood pressure. So I gave the patient PRN blood pressure medication. The patient had pain as well. I administered pain medicine to the patient sometime around maybe like 10 p.m. together with the patient's night medications, but sometime around midnight the blood pressure still came up. Had to give the patient PRN blood pressure medication. 4 hours later, the patient's blood pressure even went from like a 188 to the 200s. And I'm like, this patient is calmly sleeping in bed. Can someone explain to me why this patient needs IV fluids running at 125? And I'm like, So I went into the patient's note and I'm like, let me try to figure out why this patient needs this fluid at this rate. Because for one thing, this patient was eating fine, this patient was drinking fine, this patient had like tons of apple juices, orange juices, bottle of water, and the patient was also peeing fine. But for some reason the patient needed IV fluids running at 125. Liver functions look fine, labs look fine, patient doesn't have any kidney issues. And I'm like, why is the patient even on IV fluid running at 125? So I'm explaining on all of these so that you should understand that on the step down unit you have to use your critical thinking. It doesn't just mean that, hey, the patient's blood pressure is 202. Hey, the patient has a PRN blood pressure medication. Okay, let's go give the patient's blood pressure medication. Or you might come and or some people might not even think that, hey, that blood pressure might be, somewhat related to the patient's pain. But the patient was sleeping. In nursing, there is something that we assume that if a patient is sleeping, then it translates to the patient doesn't have pain. So this patient's blood pressure was 202 and this patient was sleeping calmly. The patient didn't even notice that I entered the patient's room to check their blood pressure. So I reached out to the doctor and I'm like, I don't understand why this patient's on IV fluids. Like, can we like reduce, if I thought the patient even needs the IV fluid, can we reduce the rate of the fluid? So the doctor is like, hey, let me look at the patient's chart one more time. So the doctor reviews it and he's like, makes sense. And then he was like, maybe the patient needs the IV fluid because they're trying to prevent a situation wherein the patient is going to go into any septic condition. But then I'm like, okay, I get it, but the patient is drinking fine, the patient is eating fine, and the patient has fluids. The patient is getting 2 IV fluids, 2 IV antibiotics. And I'm like, all this fluid in the patient is causing this blood pressure. So the doctor was like, makes sense. So he gave an order for a rate change. So he had to drop the patient's IV fluid rate from that 125 to 50 ml per hour, which even made sense. And then at shift change, I told the nurse, the day shift nurse, the morning nurse, and I'm like, these fluids don't make sense, because the patient is getting 1,000 cc in like what, maybe in like 8 hours, and then the patient has vancomycin 500 ml every 8 hours, and then the patient has ampicillin 100 ml every 8 hours. Like, combine all of these fluids together with what the patient is drinking and all the juices the patient is just asking back and forth. I'm like, this is a very good recipe for high blood pressure, like hypertensive urgency maybe. So the day shift nurse was like, hey, she's going to run it by the doctor and see if the patient even needs the fluid in the first place, because the patient is very young. The patient doesn't have any kidney issues. The patient doesn't have any reasons to flush their system, so to speak, that they should be on that fluid, and worst of all, for it to be at 125. So I'm explaining all of this so that you can understand that the step down unit is not a unit where something will happen to a patient and then you just go, oh, the doctor's order said this. You have to use your critical thinking. You have to look at labs, you have to look at doctor's notes, you have to look at how the patient has been faring. If you had the patient the previous day, you have to be like, hey, the patient on my previous shift, or the patient from previous shift was like this, so why is it like this? So you have to marry all these information together to make an informed, calculated decision for the patient's sake. Meanwhile, my other fourth patient was chilling. Well, this is a patient who was even on comfort care, and the patient was scheduled, or is scheduled to be discharged today. So that was a rundown of my shift last night. So I had two patients who were more sort of like respiratory issues. One came for something respiratory related. The other one came for kind of like a stroke, seizure-like diagnosis, kind of situation. And then the other was like comfort care, and the other one was more so like pain from a procedure. So I explain all of this so that you can understand, oh, so this is the sort of patients that I would have on a step down unit floor. Or this is the sort of things that can happen to certain step down unit patients. Or this is the sort of shift that you can have on a step down unit floor. The question now comes, do I feel like it was so much pressure on me? I would say the beginning of the shift kind of felt like there was so much happening at once. But once it was like midnight, I felt like it was chilling. So I would say beginning of the shift, yes, there was the pressure, but after midnight, everything was fine, was chill, it was okay. Given the patient still with the respiratory issue, I still had to be going back and forth and checking their respirations, because the telemonitor still kept beeping, but it was just like for a second or so, but again, you still have to go check on the patient. But aside that, there wasn't like any major intervention that I really had to do on the patient. It's more so just checking on the patient for their safety. And yeah, that was how my shift went by last night. Do I still love my step down unit? I would still say yes, because most of the times when I'm floated to the med-surg unit, I feel like it's so slow. I feel like it's so boring, because it's like the patients on the med-surg unit floor, to me, the way I explain it is that most of them are just there taking their regular home medications. There's nothing for me to be using my critical thinking. There's nothing for me that is keeping my adrenaline pumping. There's nothing that is keeping me high on my dopamine. So I just feel like med-surg is just too slow pace for me. And I would always say that I love my step down unit. I don't know, the sun this morning is really crazy, so I had to put this just to shield me a little bit. So if you see the light and the shine from this side, just know it's the sun. Nothing I can do about it, but well, here we are. And yeah, that's more so why I love my step down unit. I love the adrenaline, I love the rush. I love the fact that the patients most of the times the patients are aware that they are in a critical situation, and they are very appreciative of the efforts that we put in, and the efforts of saving their lives, in quotes. I love the fact that we don't have so many patients to like be running back and forth for. To me, I feel like it's enough. But mind you, in as much as last night for me was kind of crazy, it doesn't mean I don't have nights that are very chilled. It doesn't mean that I don't have night shifts that are more crazier than this. And so yeah, that was what my shift last night looked like. Again, it's my hope that I would make more videos as these ones live videos, just to explain to you guys what a step down unit floor looks like, what the shift looks like, what the patients look like. Again, there's never going to be one shift that looks similar to the other. You would have some shifts, you will have many shifts that would be slow paced, but they will never be alike, because the patient and the patient acuity will always be different. Patient age, the acuity, maybe the doctors, the situations, the nurses and the charge nurses who are there to help you. The situation will always be different. So every shift will always be very different. But yeah, last night that was what my night shift looked like. I don't know what other possible questions anyone could have with regards to the step down unit shift. If you have any questions, please drop the questions in the comment section, and I'm going to look at it and I'm going to answer it in my next step down unit shift live video. I'm just a little bit distracted because I'm in a kind of like a shopping center and people are walking around, so I'm just like a little distracted because people are looking at me. But anyways, I have to do what I have to do. And so guys, I hope that this information was helpful. If you have any other questions, please don't forget to drop them in the comment section. If there's any other thing you want me to explain further, do let me know and I'll be more than happy to explain it further to you. I want to give or create more awareness with regards to what the step down unit is. I want more people to join the winning team, which is the step down unit team. I want more people to be knowledgeable of what the unit is, the sort of patients that we have, the patient load, the patient acuity, what management looks like on the floor, what teamwork on my floor looks like. Because most of the times when they call the rapid, everybody, all the nurses come to, I don't want to say all the nurses, but the other nurses come into your room just in case you need help, just in case the patient codes or goes into code blue, and we need to like gather other supplies, maybe bring in the crash cart, flushes and all of that. People start taking their roles and all of that, CPR and all of that. So most of the times when they call a code, the other nurses, the tech, the charge nurse especially is going to come in, teamwork. What else? If there's any question, like I've said, and I feel like I'm repeating myself, sounding like a broken record at this point, if you have any other questions, please drop it in the comment section and I'm going to answer it in the next live video. You can tell I'm very tired. It's probably time for me to go take my shower and crash. Again, I'm working tonight, third night shift in a row. I'll be doing 4, which is my normal. I love clustering my shifts together, because when you cluster your shift together, they tend to give you the same patients for all shifts. They try as much as, except if the patients expire, or except if the patients are being discharged during day shift, or if the patients have been downgraded, or if the patients have kind of coded or moved up to ICU. Most of the times they would continue the same patients for all 4 shifts or 3 shifts that you have back to back. And it's even much more easier because you already know the patients, you already know what to expect, you already know how to take care of their care, you already know what to document, you already know what to assess, you already know what to focus on for these patients. And so I love clustering my shifts together. We can talk about that in another live video, but for now, if you have any questions, anything you want me to throw more light to enlighten you more about the step down unit, please don't hesitate to drop your questions. And from me to you guys, take care, have a lovely week, and please don't forget to subscribe, like and share, and join us on this on this journey to enlightening people on what the step down unit is all about. Bye guys, and have a lovely weekend. I'll see you.